Thanks, Rob, and good afternoon, everybody. Just to let you know, the Federation is the national representative of investor-owned hospitals. We represent over 1,000 hospitals across the country, teaching, non-teaching, urban, rural, inpatient rehab, long-term acute care, psychiatric cancer. So we kind of run the gamut. We certainly appreciate CMS and ONC setting up this session today. It's a very important issue and one I'm glad there was follow-up on. It's really important that this dialogue continue. We as an organization agree with most everything we heard today and add our voice to many of the points that have been made, both by our hospital colleagues as well as our physician and vendor partners, and this dialogue does need to continue. We have obviously many overlapping themes we've heard today, and so in my brief remarks I'm going to focus on 4 areas that we wish to emphasize. There are multiple reasons for higher coding in the emergency departments now. As I sat here today, it really occurred to me, isn't that in part the reason why the Affordable Care Act was passed? We have many, many uninsured people growing by the day who are not getting primary care when they need it and end up showing up in emergency departments when they have a developed medical condition. I hope that we can sit here in 3 years and look back and say that the trend has gone downward because of the Affordable Care Act. I really think that that's one of the things we need to keep as a broader perspective about this. Clearly, my hospital colleagues this morning did a wonderful job in showing you the data about the higher acuity, but also there is a baseline of just better documentation will lead to better coding. As we prepared our statement, we talked to many of our members who brought in their physicians and did talk about how there has just traditionally been undercoding, simply because either one, there's not enough documentation, but illegible writing of documentation in the record, and so from a concern of safety to code to a lower level so as not to be scrutinized later. So I think more complete documentation leads to better coding, and improved coding is not necessarily upcoding per se. And finally, I think that standardization of medical documentation data sets is not necessarily a bad thing. I was concerned and moved by hearing the statement this morning about a Medicare carrier who may just deny a claim simply based on the fact that it looks a lot like a previous record from a previous provider. I think what we're trying to do here is develop data sets at the local provider level that are consistent so that we can then plug into a larger health information network where there is better population health because we are sharing information. To the extent that that involves some standardization, it seems like that's a good thing, not a bad thing. And so I would hope that at the claims level that people aren't necessarily interpreting that in the wrong way. My second point is EHR adoption in hospitals is really occurring within a culture of compliance. Hospitals have operated compliance programs for many, many years now. Part of that is overseeing not only the billing and coding before it goes out the door through checks and balances, but follow-up auditing and monitoring, and obviously responding to medical post-payment reviews by government and other private payers. This is not an entirely automated prospect for us. As we talked to our members, we clearly heard that the EHR would help lead to a point, but then there's a manual intervention. And so if something looks like it's inappropriate from a repetitive standpoint or something else that raises a concern in the documentation, there then can be manual follow-up. So it's not a completely automated system, and it will remain to be seen whether it really ever could be in a way that, that would be without checks and balances. But I'll make another comment on that in my next point. Third, as EHR products continue to mature, more safeguards against improper use of documentation should really be built in. There are products out there now. We've heard about the carry forward of information. As we understand it, there are some products that mark that, so it's clear that it's information that's been carried forward. Others do not. It's just an example of as that field and that marketplace matures, that there will be more safeguards in place to be able to do this. Hospitals are in a difficult position because many of us are buying either products off the shelf or designing products with the vendor that basically we provide care and we're using the utilization of what we're given. So as those products develop, we'll be better at what we can do, and it's important for us to partner with the vendor community to be able to give the necessary feedback about what we think would be helpful in those products, and we would hope that ONC would look at that area for future certification standards as well. And finally, I think policymakers should just strike a proper balance between the level of scrutiny on individual utilization of EHR products and put the necessary focus on providing care. I thought both Dr. Stark and Dr. Mitchell made excellent points today about how onerous it's become on physicians to really document. I think that the need for documentation is very important, but we certainly should not let it usurp the patient care. We need to be efficient in the system. We certainly are looking at a system where we are investor-owned hospitals. I'm not sure that we've ever seen a strong business case for EHRs, but we know it's the right thing to do for patients, and we're doing that. But if we're going to have too much onerous oversight about how those are used or what's actually required to that, it's going to drive cost. It's going to deny access because it's just going to mean that physicians and hospitals can treat fewer patients, and it's ultimately not going to drive some of the key policy drivers that both the Affordable Care Act and CMS have stood for a long time. I again say that it's a pleasure to be with you today. We look forward to continuing this dialogue with you, and thanks again to ONC and CMS.